Hi, everyone, and welcome to our Nerva webinar series hosted by Mindset Health. Most of you know me. I am Claire. I am the research lead, and I'm really grateful to be joined by Dr. Jeffrey Nathanson, who is a gastroenterologist and co-owner of Comprehensive Gastrointestinal Health in Illinois. Dr. Nathanson has always had an interest in the mind-gut connection, and through Comprehensive Gastrointestinal Health, he and his partner have created a new style of GI practice that integrates the latest in gut health research with personalized nutrition and behavioral health support. The multidisciplinary team at CGH includes board-certified gastroenterologists, nurse practitioners, registered dietitians, clinical psychologists, behavioral therapists, health coaches, and physical therapists. So really the dream team all together under one roof. This collaborative approach ensures that each patient receives tailored care that addresses all aspects of their gastrointestinal well-being. So we're really grateful to have Dr. Nathanson here talking to us today. And if you don't mind just sticking around for a few minutes after the Q&A, we are also launching the Nerva Clinicians Course. So I will pass it to you, Dr. Nathanson, and take it away.
Great. Well, thank you very much, Claire, for that very kind introduction. And thanks everyone for coming out this evening or this morning, wherever you may be. So today, I hope to give you a bit of a different perspective on gut-directed hypnotherapy and its role in the care of individuals with IBS. I'm not an academic, and other than a brief mention on a slide or two, I'm really not going to talk about the data that demonstrates the efficacy of gut-directed hypnotherapy. And I'm not a therapist, so I'm not going to go into depth about how to deliver gut-directed hypnotherapy or how it affects change in patients. Really what I am is a gastroenterologist who practices in the community. I'm on the ground every day seeing patients with IBS and functional GI issues. Every day, many times a day, dozens of patients like this each week and hundreds every year. I actually just a little while ago did a little back of the envelope quick guesstimate of how many IBS type patients I've seen in practice over the course of 20 years. And I'm conservatively estimating that I've had over 10,000 patient interactions with individuals with functional bowel disorders. So really my goal is to try and tease out the nuance of IBS in clinical practice, who may benefit from GDH, and how to talk about it. But before I do that, I want to tell you a little bit about my own professional journey, as I think this will enable you to appreciate why this particular topic really has resonance with me. So 25 years ago, I attended a well-regarded GI fellowship program here in Chicago, and we learned how to do colonoscopies and how to treat GI bleeding and how to take care of very sick patients with cirrhosis. But when it came to IBS, it was a little bit poo-pooed. When we talked about management, it was really about medications. So when I graduated, I went out to the suburbs and started practicing in the community. And suddenly every day I was seeing one patient after another with functional bowel issues. For my first 10 years or so, I got really good at the medical management of IBS. But as I got more and more comfortable with this approach, and I kind of was able to step back a little bit and really listen to the patient and observe the patient, I was talking about medications, but what they were talking about was what they were eating, how they were worried about going out to restaurants in public because of their symptoms, or really just kind of more broadly, how disruptive their IBS symptoms were to their entire lives. So when it began to dawn on me that the more I thought I knew about IBS, the more I realized the limitations of what I knew and what I was doing. And I started to feel like I was practicing gastroenterology with one hand tied behind my back. I wasn't really meeting patients where they needed to be met. And I started to feel like I was failing my patients. And then COVID hit, and this was, to me, really the straw that broke the camel's back. It was a time, obviously, of tremendous anxiety. We're all worried. We felt isolated. Many of us were working from home. Our kids weren't going to school. We couldn't see our elder parents. And what I was seeing in practice was that the sheer number and the severity of functional GI issues just really blew up. So it was at that point I decided to shift gears. I left the big hospital system that I was employed at and joined my current partner, creating a new kind of GI practice, one that really focuses on the individual and wellness. And looks broadly at them in their entirety. We called it Comprehensive Gastrointestinal Health. And in this practice, as Claire mentioned, not only do we have gastroenterologists, we have 5 GI dietitians, a clinical psychologist, a gut-directed hypnotherapist, a physical therapist, a personal trainer. And really with these resources, what I have found that I can finally provide the type of care that my functional bowel patients really need. So I'm still seeing dozens and dozens of patients with functional GI issues every week, but now what I'm seeing is so much more rewarding because with the support really of this entire comprehensive GI team, the patients are able to make behavioral and lifestyle changes that really positively influence their IBS. And I'm seeing them finally feel better at a way that I really wasn't appreciating in my patients prior to this opening this practice. So with that as the background on me, I want to talk to you today about my objectives. So really, I'd like to try to identify, and I'll talk to you a little bit about what this means in a bit, but the particular management subtype of patients with IBS, and in particular for the purpose of today's talk, who are those patients that are most likely to benefit from gut-directed hypnotherapy? And then equally important to identifying the patients that are most likely to derive benefit is really how to go about talking to these patients about gut-directed hypnotherapy. So I'm going to start with a patient example. So this is a patient I saw a few months ago, a very typical patient, a 42-year-old female with IBS. First time I was meeting her, but she had had symptoms that dated back years and years to when she was a teenager. She described frequent bloating and abdominal discomfort, although she would also have stretches of both constipation and diarrhea. In addition, she would have these occasional bouts, a couple times a month, where she would have severe abdominal cramping that could be associated with urgent loose stools. She had no bleeding or vomiting, fevers, weight loss. All of her labs and stool tests and endoscopic colonoscopic evaluation were normal. So we'll kind of cut to the chase in that there was the etiology here. The diagnosis was IBS, functional bowel issues. We excluded she had already excluded other possible etiologies. So when I say the term management subtypes, when I'm approaching this patient, I'm already beginning to think about what's the primary driver of their symptoms. And I tend to think about 4 categories: diet, motility, dysbiosis, and visceral hypersensitivity. And I would say that often there is one of these that stands out as the most most dominant trigger to their issues. And it's really just kind of teasing out for that individual what's the major driver. So first, diet. And this is often an easy entry point for patients because they often are focused on what they're eating and how it impacts their GI symptoms. So for this individual, she described that her symptoms often, but not always, followed meals. She had tried on her own eliminating gluten and dairy, but didn't find that it was consistently providing her with relief. Nonetheless, she continued to really minimize the gluten and dairy in her diet. At some point, again, she's had this condition now for decades. She had seen a dietitian and had been tried on a low FODMAP diet, but she felt like it only really helped at most a little bit. Nonetheless, she would eat very bland, and she was often afraid of accidentally eating the wrong thing, hence the limitations in her diet. So to me, when I look at this, the particulars on this patient, to me, this doesn't really jump out as specific foods driving her symptoms, but rather when the act of eating itself seemed to cause some reactivity in her GI tract. So motility. So I'm often trying to sort out whether there's an intrinsic issue with the way that individual's bowels move or don't move. So for this individual, for this patient, she described periods of constipation and other stretches where she would have looser but not watery stool. But she did not have, and I always trying to tease this part out, where she would have constipation that would kind of build and build and build, sometimes over many days. And then with that distension, have a swing or a pendulum swing, as I like to think of it, in the other direction and then have diarrhea, which is really a constipation-driven symptom where there's resulting overflow and a spasm and then overflow and then the resulting diarrhea as opposed to a primary diarrhea-driven process. And I'll also mention that she described some days that she would have pretty normal-looking bowel movements. I also like to talk about her symptoms. She described bloating and discomfort. And some people, the bloating and discomfort directly ties in with the bowel dysmotility. So, often when patients, some people, when they're constipated, they get more bloated, they get more uncomfortable. But for her, maybe a little bit, but she would feel bloated and uncomfortable really most days, independent of whether she was constipated or not. So again, doesn't seem to be that this is as simple as if we get this individual's bowels moving more effectively, she'll have less discomfort, she'll have less bloating, and she'll have more consistency with her stools. So dysbiosis, as we're all generally familiar, we have a very complex microbiome living in each of our intestinal tracts with trillions and trillions of bacteria. Certainly an exciting area of research, which I'm not going to delve into today, but it does seem a subset of people with functional bowel issues has to do with some disruption in that balance. So I'll often try to figure out whether this person may be at risk for dysbiosis. So there's certainly aspects of one's history that might suggest that. For example, metabolic disorders such as diabetes, prior intestinal surgery. This patient had none. The other thing is sometimes symptoms are a little bit more suggestive of dysbiosis. So often these patients may have a lot more gas complaints, not just bloating, but gas. So whether it be belching, flatus, a lot of stomach noises. Again, this individual did not have any of those. And then I'm always curious to ask if patients have been on antibiotics for unrelated reasons, how did they feel it impacted their GI symptoms? A lot of people won't say, I didn't notice anything different, but there will be a subset of people who will, I've heard this again and again, will say, oh, my GI tract was great. It was the best it felt in a long time. So that particular subset may also, directing one's management toward dysbiosis may play a more important role. Another thing I'll ask everyone, regardless of their GI complaint, is what's the most problematic part of these symptoms? I want to understand how it's impacting their life and also how it's impacting their just more global well-being. So for this individual, she said that she was often afraid of having an episode. These episodes, again, a couple times a month, where she would get severe cramping and have to get to a bathroom urgently or at risk of having an accident. So she was afraid to stray from a very bland diet. She was often worried when eating out in public. She would show up in the restaurant. The first thing she would do is figure out where the bathroom was, and it prevented her from enjoying the meal or enjoying the company she was with. So she often would avoid eating in restaurants. And in particular, when she would travel, this anxiety was further compounded, the disruption of her routine and the familiarity of the food, and then the air travel itself. So we hear a lot about anticipatory fear and sort of trying to control the situation because it otherwise feels out of control. So to me, this is often the entry point where I'll start talking about the gut-brain or mind-gut connection. And even just mentioning this, I will say to the patient, some people will experience symptoms that are related to the mind-gut connection. Our mind is very intricately tied to our GI tract, and people may experience that, for example, when they might get a nervous stomach before they have to give a talk or before something important, and they may have to go use a bathroom. So a lot of people can kind of relate to that. But I'll add that for a lot of people, this is it's actually quite common. People don't necessarily talk about it, but they talk about it with me, and it's very real. And I'll also always comment that this is not something in the individual's head. This is where I might talk about serotonin, how most of the serotonin in the body is actually in the intestinal tract, not in the head, not in the brain. So I want to make sure, again, I'm always looking for opportunities for people to say that this is real, you're not alone, and make them feel, often these people feel isolated and they feel shameful about their symptoms. At that point, I'll often ask more explicitly about stress and their symptoms, and I'll use examples. So if it's a college kid, I might ask about If they've got finals, do they tend to have more GI issues? If they've had some argument with a friend or a family member. Certainly young parents, I might ask about if they're not sleeping as well because of their young children. Or I might ask someone about their work and if it's stressful and how does that impact? They tend to have more stomach issues. And I'll always point out that sometimes it doesn't necessarily register up in their head. It may just manifest with the GI symptom, but is the environment itself stressful? Often I'll see a lot of very high achieving individuals, successful in their personal and professional lives, who don't register stress or anxiety in any other way other than their GI symptoms. And then I will ask, though, a lot of these patients will have a history of anxiety. So we'll ask, have you been on any medications for anxiety? Have you worked with a therapist? And I'll point out with our patient, she was on an SSRI, and she was seeing a therapist to address her anxiety as well. And then it's some of these patients with IBS and hypersensitivity will have other hypersensitivity issues. Some of those are in the GI tract, for example, globus sensation, functional chest pain. And then sometimes people, and this is pretty well borne out in studies with IBS, they will have other, I like to call them hypersensitivity conditions outside the GI tract. So fibromyalgia, migraines, and again, validating. I will say that there's some common pathway that we haven't really defined that often links these conditions together where the nerves throughout the body are hyperreactive. I'm going to talk to you a little bit more in a sec about how I talk about this sort of thing. So this particular patient has that fourth driver of their IBS symptoms that it's described. People use different terms, but I like the term visceral hypersensitivity. So visceral hypersensitivity is one of the subtypes of disordered brain-gut interaction. So there's dysmotility. So those are the motor nerves, the way things don't move properly, whether people have constipation or diarrhea or alternating bowel habits. This is more on the sensory end of the spectrum, where people will have hyperreactivity to normal stimuli. They might eat, and then they need to run to the bathroom. They might eat and feel very bloated. There's also an intertwined hypervigilance where patients will recognize that when they're in situations, for example, when they eat, they may get bloated. So they are very attentive to that, which of course then can create a positive feedback loop where if they eat and feel discomfort or have an urge to go to the bathroom, their hyper attentiveness will make those nerves more reactive, and then those symptoms will become more likely to occur. And then often, as is the case with this patient, these individuals will have anticipatory anxiety and will avoid certain situations. So I want to talk a little bit about how I then discuss the gut-brain interaction, or in this case, gut-brain miscommunication. So I'll often start with the patient. I'll say that our GI tract has its own nervous system. It's called the enteric nervous system. And there are really two types of nerves. There are motor nerves that go from our brain to our stomach and intestines and tell it to move. So, we eat, it squeezes, peristalsis, we digest, it squeezes, and eventually we eliminate. And then there are sensory nerves that go the other way. Tell us we're hungry, we're full, we need to go to the bathroom. And in some people, for reasons we only partially understand, things don't always move right and things don't always sense right. And then I talk about what I call the challenge. The challenge is, despite this being quite common, we still don't have a test where we can do a blood test or a colonoscopy or an x-ray and say, here's the problem, just fix it. And it doesn't make it any less real. Again, I'm always looking for opportunities to validate. But it does make it a little bit frustrating for patients. So I think we need to think about this a little bit differently. The example I will often use is that of headaches. So I think most people can relate to headaches. Most people have had a headache at some point. But I'll say if sometimes people get new headaches or more frequent headaches or severe headaches, debilitating headaches, and then they may see a headache specialist, a neurologist, and that headache specialist may order a CAT scan or an MRI to make sure there's nothing serious, like a tumor. And most of the time, great majority of the time, that CAT scan comes back looking normal, and that's good. We like normal, but it doesn't make the symptoms any less real. That individual's still struggling with these disruptive, at times debilitating headaches, and we got to come up with a management strategy. And for headaches, it might be lying down in a dark room, or avoiding chocolate, or taking acetaminophen, or taking a prescription medication. And I say it's the same sort of approach with these IBS functional GI issues. And I think for some reason, maybe as the mind got with the head, because that's where the mind is, it's a little bit easier to draw that connection. And people experience GI symptoms. It's a visceral experience, and it's a little harder for them to grasp that tests aren't going to give you them an answer. And then I'll often segue into what I talk about as the whack-a-mole approach. So many of you are probably familiar in an arcade with that game where you have the hammer and you're trying to whack the moles, but they pop up before they disappear. Well, I talk about how often in individuals there may be particular triggers to these symptoms. Maybe it's something they ate. Maybe it's a particular stressful situation. Maybe it's their bowels aren't moving as well. But you can play whack-a-mole trying to constantly identify the triggers and knock them all out. But ultimately, the underlying common denominator here that links everything is it's that hypersensitive or hyperreactive nervous system, the GI tract. So rather than, not that we shouldn't try to identify triggers, but often the best approach is to target the underlying hyperreactivity. So then I will talk about options. And I talk about options first about not necessarily in this order, but I talk about there are medication options. Today, we're not talking about medication options, but I will then, of course, talk about behavioral, where we're going to focus now. And as many of you know, there's really good evidence in two particular areas with IBS: cognitive behavioral therapy and gut-directed hypnotherapy. So I want to talk to you about the particular subtypes in my experience that might benefit, that I kind of lean towards cognitive behavioral therapy, and those that lean toward gut-directed hypnotherapy. I will tell you that this is not evidence-based. This is just coming from seeing thousands of patients, and also from talking with my gut-directed hypnotherapist and my clinical psychologist who does cognitive behavioral therapy, who are the subtypes of patients that seem to do best with one or the other approach. So I'm going to, let me talk about the gut-directed hypnotherapy first. So again, these are not absolutes. These are, I think, a little bit of trends that we note. But I think, in clinical experience, there's truth here. So the gut-directed hypnotherapy patients, I think, are the individuals where pain is a big part of their symptoms. The symptoms themselves become very disruptive. Like our patient, for example, these attacks of abdominal cramps where she needs to get to a bathroom are when they hit her, I mean, there's nothing she can do. It's severe, extremely disruptive. She's not only in pain, but she's embarrassed, the shame she experiences. So very disruptive. I will often then talk to them a little bit about their experience with meditation. We're going to talk about how I word gut-directed hypnotherapy in the past as I talk to them. But I want to hear about whether they have explored meditation, sometimes yoga. Some people gravitate towards that. Some people shy away. They say, I can't do that. And I kind of feel out their open-mindedness, because I think, this is a little bit, for many people, not something they've heard before. May seem a little unorthodox, and, we have good evidence, but for some people, it seems to come a little bit out of left field. Now, the patients that I think maybe I lean more towards cognitive behavioral therapy. So these are individuals who have symptoms that they clearly are associated with recognized stress. They have to give a talk, and then they have to run to the bathroom right before they start. They often have insights. There is a strong anticipatory component that they recognize in advance. And these people tend to be more in their head in general. They're often in their thoughts and less visceral in their experience. And I think, sometimes when I talk to them about the option of gut-directed hypnotherapy, they just kind of shy away and say that this isn't really for them. That doesn't mean it can't be broached, but I think it's important to recognize where the patient is and meet them. If you try to do too much too quickly, even if you think they could benefit from, say, gut-directed hypnotherapy, that may chase them away. So Briefly, gut-directed hypnotherapy had its first randomized controlled trial published over 40 years ago in Lancet, and the efficacy is really indisputable. There are more than a dozen randomized controlled trials. There have been many large consecutive case series, and while it's been studied primarily in IBS, there is certainly some data to support in other functional issues. And I will tell you anecdotally, I will use gut-directed hypnotherapy for functional chest pain, for globus sensation, and I'd love to. I know that there are some studies underway. I'd love to see the data. My experiences, and they are often very helpful. And again, the common connection here is it's again the hyperreactivity of the entire GI tract. It can kind of bust through anywhere in there. So Nerva, as you're familiar, is a digitally delivered gut-directed hypnotherapy, and there is randomized controlled data demonstrating its efficacy in terms of not only improving symptom burden, but reducing abdominal pain and improving quality of life. And studies have shown that it is equally effective as face-to-face behavioral strategies. So, I have the good fortune of having a gut-directed hypnotherapist, and yet I will often use Nerva. I think if I had Nerva back before I started this practice, it would have been really wonderful because I didn't have other resources. But even now, I think that sometimes seeing a gut-directed hypnotherapist, there can be some practical considerations. There's cost. It's not always covered by insurance. There may be time commitment and availability. Nerva is a lower bar of entry in terms of all of those. It takes less time. It is far less costly. And I think for some people that also may not be quite ready to commit to talking to a therapist, and I have many of these. Again, I have a gut-directed hypnotherapist, but people are just like, they're a little gun shy on that and open-minded enough to consider this, but not necessarily make that leap. So sometimes Nerva is perfectly suited for those individuals and maybe, just as effective. Sometimes it's a bridge to get these individuals to gut-directed hypnotherapists. So it has a critical role here in helping my patients. So lastly, I'd like to talk about just what I say about gut-directed hypnotherapy and Nerva. I will say that what it involves is guided visualization, where using both the visualization and diaphragmatic breathing, you kind of get to the individual, you get to a relaxed state, but one of heightened awareness, and one where in that state, you can get more in touch with your bodily functions and downregulate it a notch or two. And, I think it's important to set the expectations. This nor any IBS therapy is a cure. Our goal here is to decrease the frequency of these episodes, the severity of the episodes, and hopefully they don't last so long. And you can, kind of use these interventions not only preventatively, but sometimes in real time to help kind of nip them in the bud. So, it's really important for particularly this therapy, which is a bit different than what patients are used to, and also involves their engagement, that they really understand what's going on. Again, I'm feeling them out as I'm explaining it, to the likelihood. Not only that they understand, but the likelihood that they're motivated to pursue it, because this requires their active participation. So are they open to it? Are they motivated? And then ultimately, a lot, as is a lot in sort of joint decision-making with patients, is the trust that you have in that relationship. And I will say that sometimes I may think gut-directed hypnotherapy is the best thing for an individual, but they may not be there. Or maybe it's the first or second time I'm meeting them. And so, these are often individuals who struggled for a long time, and sometimes you need to take steps first. So maybe we'll look at the diet first, or try something for dysbiosis or medication for some of these GI symptoms. And what I'll do is sort of talk about, what we'll do is often, with IBS, there is not one treatment that suits all. Everyone's a little bit different, and we sometimes sort of come up with our initial plan, and it may work, or maybe it works to some extent, and then we have to tweak and adjust. And sometimes it doesn't work, and we have to go to plan B or plan C. And with IBS, sometimes you have to go to plan F or G. But the great majority of times, I also want to, often these patients are feeling pretty hopeless. I'll say the great majority of the time through this process, and it may be a process, often is a process, we will get you to a point where you're going to be better. Where your quality of life is less negatively impacted. These episodes won't happen as often. They won't be as bad, and you'll kind of know how to nip it in the bud, and hopefully they won't last as long. And again, it's all about that collaborative approach. So not only in the initiation of the care, but in terms of scheduling the follow-up and ongoing communication. So with regard to this particular patient, so she agreed to try the Nerva app. I saw her again about 8 weeks later, and she definitely was better. I mean, she described that these bloating, discomfort, and bowel fluctuations were less pronounced. She was about 50% better, which I consider a definite success. Most importantly, because again, we figured out what was the most distressful aspect of her IBS, and it was these severe episodes of cramping and loose stools. And she hadn't had one in 8 weeks, and she was getting like a couple a month on average. So it seemed to be really helping her. And as we began to sort of lower that with less episodes and sort of the time from those episodes, there was a little less hyper attentiveness, hypervigilance, a little less anticipatory anxiety. And she was actually able to travel to visit her mother in California, which in the past was difficult for her. And she had previously canceled the trip as well. So, I'll mention that gut-directed hypnotherapy is just one facet of what we're doing here. After this meeting, I did encourage her. As I mentioned, she was talking to a therapist about her anxiety. I said, hey, why don't you mention to your therapist about your GI symptoms, which she hadn't talked too much about, and say, hey, is this something that maybe you can integrate? This therapist was familiar with cognitive behavioral therapy to help her a bit. And I, of course, mentioned that we had a cognitive behavioral therapist, and sometimes people might benefit from doing a few sessions with our own. And then one concern I saw in this individual, and we'll often see with a variety of patients, is that what they eat isn't necessarily the driver of their symptoms. They often will get quite restrictive in their diet because they're feeling confused, and they sometimes get symptoms after eating, and they start to restrict, and they start to get anxious about eating, and they often are not eating in a healthy way, which isn't going to be good on many levels. So once we're kind of going in the right direction, I think having a GI dietitian in this particular patient, as I do with many, to help them get more comfortable expanding their diet and more at ease eating, I think that's an important part of her recovery here as well. That's all I got. So, and I'm hopeful that my own experience just working with many patients with these sort of symptoms, just kind of the nuance of how to identify the ones that are going to most benefit from Nerva and gut-directed hypnotherapy, and then really just some of the, I think, skills just to effectively communicate with them to enhance the likelihood that this intervention will be successful. So thanks for your time.
Thank you so much, Dr. Nathanson. That was incredibly insightful, and I think you're very lucky to have the type of practice that you do. So I'll jump in with a couple questions, and if there's any questions, feel free to submit them in the Q&A box as well. Because of your unique practice where you do have access to a wonderful multidisciplinary team, do you have any suggestions to providers who are listening who don't have access to that type of team, and how they can sort of build that for themselves, whether it's integrating digital products or connecting with other providers?
Mm-hmm. Right. So I practically speaking, I think those are the best two options. And they didn't exist 10 years ago when I was practicing. But certainly there is a variety of options in terms of diet that can be done through apps. Monash has an IBS app that I previously would use to use or I've even used occasionally, although dietitians are usually a lower bar for patients to see. But now there are certainly access to virtual providers, which is really nice. There are a number of entities, I don't necessarily have to delve into all their names, but that now will provide that for patients. And I know I have a colleague not in my practice that now has brought AI into that picture in terms of identifying the patients that would most likely benefit through a screening process, and then that actually is able to effectively, when identified, make some referrals as well, which sounds pretty interesting. I don't know all the details, but I think virtual care makes this a lot easier than having a dietitian on site. I always think dietitians and behavioral therapists on site are wonderful, but it's certainly as our population gets more and more comfortable with virtual care and digital care, this is the direction I think a lot of it is going in.
Awesome. Question here. This is submitted from a dietitian. I'm curious about SSRI or SNRI use, IBS, and the possible use of gut-directed hypnotherapy's role. I'm a dietitian, and I've observed some of my clients' IBS will get worse when coming off these medications. Anecdotally, it seems that clients notice an increase in symptoms when coming off or changing these meds. I haven't delved into the research, but this makes sense to me given the roles of serotonin. First question is, have you seen this correlation? And second question, would gut-directed hypnotherapy help with this? Or is your hunch that it's really a medication issue?
Yeah, great question and very insightful, because I definitely, when I ask questions of patients, when I talk to them about their history of anxiety or mood disorders, I will ask if they have been on medications. And if they say, well, previously I was on this SSRI, I will ask, when were you on it? Why did you stop? And it is not uncommon that they will be coming in and these symptoms, they stopped 3 months ago, for example, and now they're having, like, their IBS is really bad. So, in that situation, from the standpoint of the medications, I will talk to them about whether there may have been a reason that they stopped it. Maybe there was a side effect. Maybe they're concerned about side effects. So we could revisit maybe going back on that medication if it was helpful at a lower dose. But I also have to understand, if they stop for a reason, they're like, I don't want to be on that medication, think about another medication. Or if they just don't want to be on medication, then we kind of put that aside. A lot of people come to my particular practice because they don't want to be on medicines, and I'm generally supportive of that initially with functional issues. Now, sometimes we have to revisit, but again, it's that trust. So I do find that behavioral approaches and medications work complementary. In fact, I think medicines sometimes lower the threshold, I should say more raise the bar, so that if people are having symptoms down here and you raise the bar, it's less likely to bust through. And that kind of bringing everything to a little bit of a calmer place allows the behavioral therapies to be more effective. So they often work synergistically, but you have, first and foremost, you need to meet the patient where they are.
Question here, this may or may not be within your scope, so feel free to pass if it's not. In patients who are having GI side effects from weight loss medications like Ozempic or other semaglutides, do you find that behavioral interventions can help patients stay on these medications if they're having GI side effects?
Yeah, that's a good question. I will say that we see a lot of patients on these medications now. We definitely see people with side effects. I generally try to sort out, is there pre-existing functional GI issues prior? If it is if this is an individual really had no GI issues and now they're having nausea or constipation, those are the two more common side effects, and they never really had anything before. I always ask, have you had a history of a sensitive stomach in the past, or bowel issues or stomach issues? And if they're like, no, this is all new, I think they're less likely to respond to a behavioral approach. Now, I will say I have had people, I just saw a patient a few days ago who was on one of these medicines, and he's now 2 years later, and he's sort of went into a spiral of what has kind of taken on a life of its own with functional bowel issues that did not predate this, at least as he explains it. So, sometimes the functional issue if because you can develop that, with the GLP-1s, if you're having a lot of issues and they're not addressed, then you start getting the anticipatory anxiety, you start getting the hypervigilance. So you can develop them secondarily, but most likely the ones that are going to benefit are the ones who have pre-existing functional bowel issues, maybe mild prior to the onset, to the initiation of these medications, but now more pronounced.
Awesome. Thank you. In your practice, you talked about CBT and gut-directed hypnotherapy being sort of an either-or approach. Do you ever combine those approaches for patients? And, for something like Nerva, where there is more of a combined approach, how do you sort of tease that out for patients?
Yeah, it's a good question. I definitely do. I think sometimes people want to just dip their toe in the water, and some people want everything done all at once. I'm not someone who, if someone has had functional bowel issues that have been going on for a long time, I don't want to throw the kitchen sink at them because they're already feeling overwhelmed. Occasionally there are exceptions and people feel desperate or their symptoms are so debilitating, but I try to go incrementally and I lean into what I think maybe is the most likely to be of benefit first. But even in this example of this patient, I thought she was a good candidate for gut-directed hypnotherapy. She started on Nerva. She had improvement, but I think there's still room to improve better. And now that she was sort of on board with a behavioral approach, she was a little bit more receptive to the idea of broaching this. And I always, when someone has an existing therapist, I usually encourage them to talk with that person first. But I say that may not be their thing. And many therapists, this is not their thing to talk about their GI symptoms in the context of cognitive behavioral therapy. So I try to, I'd say that by all means, that therapist sounds like you have a really good relationship addressing your anxiety or your mood disorder. But maybe we'll have you do a couple sessions with our cognitive behavioral therapist specifically on your GI symptoms. So it is additive. I do see there's potential dual benefit, but I just will often take it incrementally.
Awesome. And last question here. How do you manage patients where you identify visceral hypersensitivity as the primary driver of symptoms, but they absolutely are not open to any sort of behavioral approach?
Yeah, that's a real challenge. And that's where the relationship is really important because, I think you have some time and since it's not a one size fits all and there's not anything that's going to cure the situation, working with where they are and maybe looking at the diet or trying a medication, even if you think the behavioral approach would be your choice, I'm always introducing the idea. And I will say, we need to revisit things after a period of time. After let's have you see the dietitian and hopefully we're going to make some real progress. And when we meet again in 8 weeks, let's see where you are. And I hope things are doing really well, but if they're not, I want to maybe revisit some of the other things we talked about, like gut-directed hypnotherapy. And if you set that expectation of revisiting, and then when you come back in 8 weeks and they're not necessarily where they want to be or where you want them to be, say, I know, you can then say, we talked about gut-directed hypnotherapy. You had some reservations, but I actually think it could be really helpful for you. There's a little downside in trying, other than a little bit of time and maybe a little bit of money. I think it would be a reasonable thing to do next and see where they are. And if, it's a little bit of a give and take and a feeling out the situation, but a lot of it is really just the trust and building that relationship.
Awesome. Thank you so much, Dr. Nathanson. We really appreciate your time and this incredibly thoughtful presentation. So I will transition now for everyone watching. We are launching the Nerva Clinicians Course. So I am going to just walk through just 5 minutes worth of information on the new course. We did previously have a clinician's course. This is the new revamped version of it. The reason why we've revamped it is because IBS care has advanced in the last 5 years, and so has the evidence, as well as the evidence that we published with Nerva and our research collaborators. So this new course is free for clinicians. I've popped the link just below if you'd like to sign up. And it, right off the back of Dr. Nathanson's presentation, talks a lot about delivering integrated care to IBS patients and the importance of that for patients to see maximum benefit. So it's really meant to equip all gut health clinicians with practical, evidence-based tools to close that gap. The course itself is 3 hours of clinical education. It is split into short chunks, so it's not just sort of a 3-hour block of information. You can split it up into short chunks and short videos. There's practical referral skills for the Nerva app, integrated care strategies. There's some great case studies. I know Dr. Nathanson just gave a great one, and there's certainly some more that sit within the course. So if you have questions about specific types of patients and whether they'll see benefit, that is a really great resource. If you complete the course, you'll also get 3 free Nerva accounts to share with your patients. So, if you get all the information from the course, we want you to be able to go on and refer and have a couple practice runs referring that to patients and getting that communication aspect down. You will also get your own profile on the Nerva Clinicians Directory, which sits on the Nerva website, so patients can find providers who've been trained and have all this information. The presenters within the course, we have a great multidisciplinary team that we put together. Dr. Megan Reel, who's a GI psychologist, Dr. Simone Peters, who is a gut-directed hypnotherapist and the clinical content creator for the Nerva app, Nancy Jaffe, a registered dietitian, Amy Stewart, a nurse practitioner, and Dr. Justin Brandler, who's a gastroenterologist. So we've got a great crew, and we'll definitely be adding content as the course evolves, but right now it's an excellent resource. So feel free to use the QR code here or click the link below. The course is live as of today, so please feel free to jump into it. Like I said, it's completely free for clinicians, so there's certainly no harm in just poking through the content, even if you have specific questions and don't need the full 3-hour course. I'm also going to pop up a quick survey just for the webinar series in general and for our webinar today. If you have 2 minutes to spare to give us some feedback, it helps us curate content going forward, and we can make sure we're giving you topics that are highly useful and highly valuable for you. With that is everything for today. Thank you again to Dr. Nathanson. And thank you to the whole team at Mindset Health who's come together to put this course out for you. It really is an excellent piece of content, and hopefully will answer lots of questions. All right, thank you very much.